Recording has started.
So before you guys all take off too, as you know, today is Nellie's last day. Okay. So sad. Will you get to dinner? Okay. Last day is Are you actually taking off tonight?
I'm still bitter. I'm not going to talk to you.
Yes. Long drive. He moved all his stuff.
You know those clean.
Three. It's terrible. Me a little bit. Yeah. He has a lot of stuff. All right. Okay. Dr. Lopez. I did my presentation in diabetes. It's just a pretty broad, yes, Stephanie, pretty broad subject, but yes, but there's a huge population with diabetes. So I wanted to learn more about it. And there's always something that we can learn about. So first, the overview of diabetes. So it's a metabolic disorder, leads to fasting and postprandial hyperglycemia. And it can be due to insulin resistance versus insufficient insulin production. So that's like type 1, type 2 type of diabetes. It's highly prevalent. 9.3% of Americans in 2012 were diagnosed with diabetes, and it's the 7th leading cause of death in the U.S. In 2010 for CDC report. So over time, hyperglycemia, why it's such an important disease to know about is the hyperglycemia leads to all these chronic and complications. So heart disease, blindness, kidney failure, renopathy, and neuropathy, foot ulcers, horrible healing. So the different types of type 1 and type 2 gestational, other specific ones, depending on if someone's septic, you might find that someone that's septic in our hospital you might find their glucose going all over the place. So those are more specific types. So I'm going to start with type 1. So there's type 1A and type 1B. So type 1A is more autoimmune versus type 1B is non-autoimmune. It leads to the same destruction. So autoimmune destruction of the beta cells that are in the pancreas, and the beta cells are the ones that make insulin. So they're unable to make insulin, so then your body can't reabsorb the insulin. Your peripheral cells can't reabsorb insulin, and that leads to hyperglycemia. So it's normally caused by multiple genes and also can be triggered by the environment. Versus type 1B, it's also destruction of the beta cells, but it's through non-autoimmune, and it's more idiopathic, so not really well known how they differ. So now type 2, it's a combination of imbalance of insulin, poor insulin secretion and poor insulin resistance. So impaired insulin secretion, that means that the pancreas can't release enough insulin, and that's so how it works. So glucose is normally the stimulator that allows insulin to be released by the pancreas. So it enters through the beta cell through the GLUT2 channels, and there's different types of GLUT channels, GLUT 1, 2, 4. And so on rodent studies, they found that GLUT2 channels, the diet affects the expression of GLUT2 channels. So if poor diet can lead to poor GLUT2 channels, so then expression, so then you have an impaired insulin secretion. And the other process of how type 2 occurs is insulin resistance, and that's more in the peripheral. So muscle, fat, liver, they don't properly respond to insulin. So even though your body's producing insulin, your peripheral aren't responding to it. So initially, even though there's a poor response, that the pancreas is able to just produce more insulin, so that your body doesn't notice that you're still normal, your glycemic levels are still normal. But eventually, your pancreas is not able to produce enough insulin and get hyperglycemic. And insulin resistance is highly influenced by genetics, so 2 to 3 times more prevalent in African American, Hispanic Americans compared to whites. It's also environmental factors that affect it. And some of the studies that they've shown increased abdominal fat. They produce more adipokines, And that leads to inflammation, which we found that it affects, it damages the cellular function. So then that leads to the peripheral not being able to respond to insulin. And then just physical inactivity. For obvious reasons, there's more. And so here kind of just explains what we were going over, the impaired insulin secretion. So that's the GLUT2 channel on the far left. So glucose enters the pancreas, so that's the beta cell, and enters the pancreas, and then through a cascade, it causes the channels, causes a channel so that insulin can be released. And then some of the risk factors that we all know of type 2 diabetes, so older age, greater than 45, obesity, family history of activity, impaired glucose tolerance, race, ethnicity, hypertension. So screening for diabetes, so there's different thoughts of this, the USPS and the ADA, so they have different screenings. So they recommend adults that have elevated blood pressure, so not that high at 135 or 80, regardless of any hyperglycemic symptoms. You want to screen for diabetes, and that's grade B. The American Diabetic Association, they recommend anyone with a BMI of greater than 25 with risk factors. If there's no risk factor, then you start at 45. Based on the recommendations. So diagnosing diabetes, we also know about different diagnoses. So an A1C greater than 6.5, that's considered diabetes, or a fasting glucose of 126. The glucose intolerance test, the 2-hour plasma, greater than 200, then it would suggest diabetes, or any sort of like classic hyperglycemia with the random glucose of 200, then you're considered diabetic. And this is just a cool little thing that gives you more of a like what's considered normal pre-diabetic versus diabetic. So the A1C if it's greater than 6.5. So what we were talking about. And then this I won't go too much into detail, but about how you evaluate the patient, what you want to make sure you ask, the labs that you want to get, vaccination as well. Considered immune compromised, you want to make sure that they have their influenza, hepatitis, vaccines. And you always want to ask about smoking cessation. You want to make sure that they're normal intensive, their annual eye exam, their exam annually, and that's more.
What is the question about the foot exam? Just for everyone. So for the foot exam, does it have to be with a podiatrist, or I haven't been with a podiatrist, and when I do diabetic foot exams, I look at the foot for calluses. I do the filament test, vibration. What also is a filament exam? Has anyone taken a podiatrist?
He does it more general. He doesn't even do the monofilament.
I would say for us, monofilament, like vascular,
Yeah. Just wondering if because I refer to podiatry in addition to what I do, so I don't know if it's necessary to refer to podiatry.
So
unless they have an
I
ulcer,
think primary should be, unless it's
or just one
healing that's ulcer that's not healing, greater than
Yes.
3 months, then you would want to.
So there is no requirement whether a podiatrist or primary care delivers that care. Just have the doctor and that's been done.
Okay.
So the rule of thumb for me, and Dr. Carlson could probably chime in, but it's kind of position dependent. So if they have a severe complicated issues with peripheral neuropathy, things like that, then you want to get another provider to look at. That's when I initiate those things. But if I have a really good managed patient with diabetes, hemoglobin control, no issues at all, I'm using tissue. That's completely different from an ophthalmologist.
Yes, that one is more detailed.
The dietary is a little more.
I do the same thing. The thing to remember though is to check every time. And there's when they come in, just like what you were saying, Nellie, because It's surprising how much they don't look at their feet. They just say, oh, they're 4 feet that direction. And so it's very important.
Yeah. I think Dr. would actually prefer that we don't refer to him for.
We don't just
diabetic.
Yeah.
Unless there's an issue, Dr. Wood.
He wants it.
No, he doesn't.
Prefer that.
Medicine here.
Unless there's also like.
Unless they have like orthotics or something too, you know, that need like special.
Okay, so then now we go into management and treatment, which was something that I always forget. Like obviously we know the insulin and the metformin, but I don't really know about the other ones, so that's why I wanted to talk about it. So that's my main topic. So based on the new 2017 guidelines came out, that's why I wanted to review them. But by the ADA, so this is what their treatment management recommendations are. So first, obviously, lifestyle modifications. You want to start with, and then so how you read the chart is left to right, obviously. But so the nutrition, depending on how complicated their diabetes is, that's where you would need more counseling. So if their A1C is not that bad, if they're good follow-up patients, if they're just newly diagnosed, then you would start in the left. So you try to maintain a good BMI, you give them a proper nutrition, like with lots of vegetables, not so much trans fat, not too much calories. And then as you go to your right, there's more red, so they're not their A1C is above 8, above 9. So then you would do more. That's when you would send them to nutrition, an official nutritional counseling. You'd counsel them on meal replacements, that sort of stuff. So nutrition, physical activity, sleep, behavioral support, and smoking cessation. So those are the things that you always want to talk about to your patients, especially if they're newly diagnosed. And especially if they're pre-diabetic, because you can get them before they actually become diabetic to go over these things. And depending on how much overweight they are, what their BMI is, that's how much you want to focus on. So that's that. And then so here just kind of goes over again, goes over this chart. So diet, you want to focus on blood pressure, A1C, and LDL. So diet that helps you lower your blood pressure and keep your LDLs within normal. So they recommend the Mediterranean style diet, which is monounsaturated fats, blend with fish, nuts, that's great bean. Counsel them on alcohol sensation or decreasing alcohol, that's a great C, and limiting sodium. And then exercise, I recommend 150 minutes per week. And moderate to vigorous and some resistance training 2 to 3 times. And then reduction, so the goal for the patient would be 5 to 10% of their current weight. That's what we should be counseling them on. So now it's that you have to assess also their cardiovascular risk factors. And so the main ones that you want to look at is hypertension, dyslipidemia. So hypertension, depending if they're not at goal, is when you want to start also prescribing blood pressure medications. Again, lifestyle therapy, so you always want to make sure that you do talk to them about your patients about that stuff. You get the lipid panel to assess their cholesterol. If they're not at goal, then you start with statin therapy. And then it depends on what their LDL is. That's how whether you do moderate to a larger dose of statin. And then so now the actual diabetic medication. So depending on how strict you want to be with your insulin or your metformin, depending on A1C. So if you want a strict A1C less than 6.5, it depends that they don't have risk of hypoglycemic episode and that they don't have other comorbidities. If you can be a little bit more lenient, greater than 6.5. I mean, once you greater than 6.5, if the patient is older, they have had recurrent episodes of hypoglycemia, if they have all these comorbidities, and you don't want to be so strict. So anti-diabetic therapy, so this is kind of the overview. So you diagnose someone with diabetes. You first always talk to them about lifestyle modifications. You start them on metformin, that's the pre-feeding, and you monitor them for the next few months. If they're not at goal, then that's when you start thinking of dual therapy, and those are the different medications that are considered that you can consider. And then you check them every 3 months. If that's not, if they're still not at goal, then that's when you start with your triple therapy. So then also, you can also just go straight to dual therapy depending on how their A1C is. So if their A1C is greater than 9, then you can just go straight into dual therapy. And here just gives you more of a better where we were going over here, but this is their chart. So monotherapy, metformin, dual therapy, you start with metformin and these other ones, and it gives you like how if they're at risk of hypoglycemia, if they have risk of weight gain or not, and then the triple therapy. Yes.
So if someone has a A1C of like 8.5 and you're giving them metformin, just to like everybody, how low do you think you're going to see it? You know,
So usually
go down in about 3 months with 1,000 milligrams of metformin.
So usually it should be for metformin, it should be like 1 to 2%.
All right. So if somebody comes in with 9 and you put them on metformin, you're going to expect them to get down to 6?
No.
So one of the things to be talking to them about is, that we may be adding something in 3 months depending on what's going on. Because some people aren't able to do the lifestyle changes
Right.
right away. So if they added the lifestyle changes and did that, you could see a significant
I was going to say that.
Yeah, just kind of when you're describing that, just keep that in mind.
So then I'm going to go more into detail on most of the medications. So metformin, obviously, we all have prescribed it or have patients that have metformin. So their mechanism, it activates the AMP kinase in the hepatocytes, and that leads to a cascade that leads to a decrease in hepatic gluconeogenesis, so a decrease in glucose formation in the liver. It also increases your peripheral insulin sensitivity. So some of the advantages is it's cheap. It's been out for a long time, so we know the evidence of safety. The study that United Kingdom, what it's standard for, but the UKPDS suggested that it may reduce cardiovascular events. It's also rare to get hypoglycemic in these medications. And then you can use it up to a GFR of less than 45. So even on some of your patients that can have some kidney dysfunction, you can still use it on them. And it's weight neutral, and it lowers the A1C an average of 1.5%. The disadvantage is long term. They've shown that you can get vitamin B12 deficiency, so you do want to be on the lookout on that. And you want to measure the vitamin B12 at least yearly, and that was found on the diabetic prevention program outcome study. We also have the GI symptoms, a lot of them will complain of like nausea, diarrhea. The lactic acidosis that we've all learned prescribed, that's pretty rare. It's only in case reports have been found, but it's contraindicated if you're predisposed to lactic acidosis. The sulfonylurea, so that's glyburide, glycoside, glimepiride. So those bind to the potassium ATP channels. And that leads to insulin secretion, so it actually leads to insulin secretion in the pancreas. So it's also inexpensive. It might decrease the microvascular risk, so retinopathy, by that study. And it can also, it's pretty, the A1C, it lowers it pretty well, 1 to 2%. some of the interventions that it's known to cause hypoglycemia. It's more common on the library than all of the other ones. It can increase weight, and more rare can cause skin reactions with pruritus, urticaria, or something eating that don't cause abnormalities in your allergies. And then the next ones are the pyroglutamate and rosiglitazone. That overall increases insulin sensitivity in the peripheral and will increase the uptake of glucose. It's also inexpensive, not rare to cause hypoglycemia. Can higher A1C decrease with these medications. On some of the some of the studies have shown that it actually does decrease risk of stroke and MI. Disadvantage is that it does can increase your weight, and it's been known to increase to be more peripheral edema, so you don't want to use it in your CHF patients. And then bone fracture can also so older ladies that have leukemia, you don't want to use it on them. And it has been known to increase your LDL with rosiglitazone. The DPP4 inhibitors, so those are the sitagliptin, so those inhibit obviously DPP4 activity, and that leads to GLP, increasing the GLP, and GLP increases, it's glucose dependent, so it increases the insulin release in the pancreas. It slows the gastric emptying and inhibits post-meal glucagon. So again, it's rare for hypoglycemic episodes. It's well tolerated. Again, some of the disadvantages, they can lead to angioedema. Possible acute pancreatitis has just been known in case reports, and it's pretty expensive. The next ones, the SGLT inhibitors. Those are found in the proximal nephron. It promotes renal excretion, so because you're creating more glucose in the kidneys, they are known to increase polyuria, GU infections. So again, these are rare for hypoglycemia. So all the ones that don't increase insulin, will be rare for them to cause hypoglycemia. It's increasing the sensitivity of it. So it actually has been shown to decrease weight, so 2 to 3 kilograms in 12 weeks has been reported. Decreases blood pressure, and one of the studies, it's shown to lower cardiovascular events and mortality. But then again, disadvantage because your kidneys are seeing more glucose, and you have higher increase of infections by polyuria. It can increase LDL, increase creatinine. Again, that one more bone pressure, and it's more expensive. So these are the GLP receptors. So it's kind of similar to this one. This one increases GLP. This one kind of acts the same way it activates the actual GLP receptors, and it should also cause the same mechanism. So increases insulin secretion, decreases glucose secretion, slows gastric emptying, increases satiety. Again, it's rare for hypoglycemic episodes, decreases weight, decreases postprandial glucose excursion, some decrease in cardiovascular risk factors. And the studies have shown that it decreases cardiovascular events as well. And then similar disadvantages to the other one, it can increase GI effects, so nausea, vomiting. Some of the may increase heart rate. Acute pancreatitis hasn't been proven, but it has been shown in some of the case reports. So now insulin. So there's different types of insulin. So the basal insulin, your long-acting Lantus, and usually when you're going to start basal insulin, you want to start at 10 units per day, or 0.1 to 0.2 units per kilogram. Your bolus insulin, those are the more short-acting. Those you can start with 4 units per day, or 0.1, or 10% of your basal dose.
combination. So those are they come with a bolus and a rapid acting or a prandial component. So those are the different options. And the concentrated ones is where they're more concentrated. The normal one is 100 units, and that one's 500 units. So it's 5 times as stronger or as more potent as 100 units. So this kind of gives you, how to start with insulin treatment. So usually, of course, you can start with the metformin, and you can either start them off with insulin depending on how their A1C is. And again, you start off with 10 units or 0.1 to 0.2. If their A1C is still not controlled, you can consider different options. So you can either consider increasing the rapid acting, so the bolus ones. So increasing it, just adding that one to your largest meal. Usually for people, it's their dinner time, or you can add the GLP one that we were talking about before, or just change it to a premix, which is the injectable ones that have the bolus and the long acting. And so if they're still not controlled, then you just keep adding more insulin basically. So then if they're still not controlled, they're able to not control for 3 months, then you can add more of the rapid acting or your prandial ones. So then this is just a table of all the onsets of the insulin types. So they all have a different onset and a peak and the duration as well. And here it gives you when their onset is and their peak. The Lantus, pretty 24 hours, doesn't have a peak, so that's why you want to use the short acting at least half an hour before the evening. And then here is just the cardiovascular disease and diabetes. Obviously, they're related. And these are more studies that newer studies that have come up, kind of proving that these medications kind of help with cardiovascular or coronary disease. So on one of the studies, they considered that medication, which is the SGLT inhibitor, and the people that they studied were longstanding diabetics that were uncontrolled, and it showed that it could decrease their coronary artery disease. The EMPA-REG outcome showed that there is a reduction of MI and strokes using the other medications that we were one, and they thought it was a random control double blind. They followed for 3.1 years, and it showed a decrease by 14%. The other study, the newer study, was also randomly controlled, and that one also showed some decrease in the cardiovascular. So those are, I normally never have, I've heard of those medications, but I don't really see a lot of patients using them. So I thought it was interesting how it has shown coronary disease decrease. So then here's just more of a slide with prevention. So prevention here, if they're pre-diabetic, you can also consider, especially if they have high risk, if they're pre-diabetic but overweight or obese, then you can consider actually starting them on metformin even before they become diabetic. And so if their BMI is greater than 35 and their age is less than 60, if they've had a history of gestational diabetes or have higher risk. So it's the new update from the 2007 ADA guidelines. And we've already talked about the 7 and 12.
So what does that tell you with some of our patients? Are they under?
Yeah, because I actually had a lot of pre-diabetics that I've just canceled them on diet and nutrition before reading about this.
What did you find in your research that when you would consider doing that? Pre-diabetes, of course, it could be.
It's a huge, yeah.
It's a big, range.
Mm-hmm.
So, did you find something specific in your research that told her I know what my practice is, right?
Well, so you want to base it on their risk factors. And so if they're pre-diabetic but their weight is okay, then you kind of just want to watch them, kind of bringing them back and counsel them on diet, and just follow them by with A1C. But if they're overweight, if they're like I said, BMI greater than 35, if they have a strong family history, and they smoke, if they have coronary artery disease, then they're at higher risk. So you do want to control it before they become diabetic.
Would you put somebody on that form if they had a 5.8?
No. Well, depends on the risk.
Normally it's somebody who would be like, we see a lot of patients who are like BMI of 40, A1C of 6.3, mom, dad, brother had diabetes, dad had a quadruple bypass, but we have them on their hypertensive medications, their cholesterol medications, and everything's looking good, but would you put them on metformin? Yeah.
Yeah, I've had actually like 2 or 3 before. I don't know, because I mean, the guidelines are just, I know guidelines are just.
So
But even now, like that's the new guideline actually from the ADA. They're recommending to put them on.
And the big reason is that, are you going to have them check their sugar every day? Probably not. Because why metformin? One of the nice things about metformin is that, hypoglycemic don't get those hypoglycemic episodes. And so, is it going to drop them down to an A1C of 4? No way. So, it's a very safe medication if they can tolerate the GI effects.
Yeah.
Although a lot of our patients are constipated, so they love having albumin every day because of the metformin. So,
It's always great.
yeah. So it might
Today.
We're all irregular because of our stress.
That's
Yes.
Keeps me very nice.
Okay, so almost done. Okay, so question.
A 60-year-old woman with a history of diabetes presents to the ED with altered mental status and a blood glucose of 35. She receives 50 grams of dextrose and her mental status improves. 1 hour later, she is confused and diaphoretic, and her blood glucose is 40. Which of the following agents is most likely responsible for her condition? Not metformin.
Good.
Regular insulin. I don't know what it was.
Yeah, right. So that's a good question.
So I don't know.
Yeah, so and then it's back to
Glyburide, insulinuria, and those ones can drop your sugar.
did you cheat?
No, what? How is this?
I'm kidding. That one increases insulin secretion, so that could do it. But what's rosiglitazone? What's the mechanism of rosiglitazone?
So that one increases, it doesn't increase the insulin, it increases your peripheral
Okay, so
sensitivity.
it's not that. It's either A or C. Probably A.
What are you gonna choose?
If Brian was cheating, then I'm going to go with A.
First of all, don't ever go with an answer choice like Brian again.
Okay.
Everybody should know that. Maybe just like you're right. Yeah.
Okay.
Yeah.
So glyburide again, it's a 2U class, it's the sulfonylurea. It stimulates beta cells to produce insulin. So you're producing more insulin, you can higher risk of hypoglycemia. So why that lady's still hypoglycemic is because they have suffering has a long duration of action. So that's why it can lead to hypoglycemia even 24 hours after ingestion. So you want to be careful. Yeah. So you want to be careful with like your older ladies. So that's yeah. So that's why it wouldn't be C or which one was it? C, regular insulin. So A or you would be between A and C because they can both. They're known to have risk of hypoglycemia. But you could correct the regular insulin because regular insulin, their duration is not that long.
That's the one that goes with this.
Yeah, this is that one here. Right here. Yeah, so their duration is just 12 hours. Okay, And the next question.
You are treating a patient with type 2 diabetes. He is currently on metformin, but his hemoglobin A1C is not at goal. He is like edits. Should how long is this person when considering management plan? Sorry. Continue oral medications, add long-acting insulin. Continue oral medications, add short-acting insulin. Stop oral medications, start turning stop. Yeah, so it's not CMD. She feels like it's sweet. I feel like it's no.
You can do
Is that you
oral
implant
and the
it
long acting.
first and so have
One
right.
in the basal.
See how they do.
A?
Sure.
Okay, yeah. So you want to first add long acting. So this one here. So you first start with your initial is your basal insulin. So you want to do metformin. So you continue your metformin normally. You add insulin, and then you start with basal insulin.
If the patient doesn't want to start sticking themselves, can you have a second one?
Yeah, you can do sulfonylureas and stuff because they increase insulin. So that's a mechanism.
You do that, or you can add something like Januvia.
Isn't that like a combo?
When you maximize the performance.
Because that's a Januvia would be like a, it's another GLP-1.
Oh, is it a GLP?
I think
Oh.
it's a GLP-1.
So GLP, yeah. So GLP are also good ones. So that's this
Yeah.
that's this
It's,
one.
it's the only oral GLP-1, I think.
Januvia?
Januvia.
And then Janamet, isn't it go with the combo?
One of them's a combo,
It's a J
it's a combo, but IHP won't pay for the combo that much. I kind of hard when they will, but I think.
What if somebody's A1C is like 10 and you're starting them out on
It's
initial
not a
therapy?
GLP.
And it's like really
DPP-4.
high.
Sorry, it's a DPP-4.
Would you start them on just metformin or could you do dual like
Yeah,
oral?
you should start dual. So on this,
Like right away, or did you
Like
like
right
we're
away.
starting metformin and then in a couple months we'll check in?
yeah, no, like here. So usually this is like if their A1Cs
Oh,
aren't that bad, but if your A1C is greater than 9, then you want to start dual because like what she was saying, if you start metformin, they're lower than 1 to 2%, but you're still not.
At that point, are you starting 1,000 BID or 500?
Usually you want to start low, especially because of the GI symptoms, they won't be able to tolerate it, so start low.
So you start with 500
Yeah.
and 12.
Yeah.
Yeah, so sometimes if I want my patient on 1,000 in 3 months when I see them, I'll, or actually I usually see them in about 4 to 6 weeks anyway to see if they're tolerating it. But I start them off, I make a prescription for 1,000, but I do 500 milligram tablets.
Oh,
And I
that's
say do 500 milligrams for a week, in the morning with breakfast, then add a dinner one the next week, then double it in the morning, then double it at dinner. So by the time I see them, hopefully in about 4 to 6 weeks, they will have been on the full dose for at least a week. And taper it up because, if you start out 1,000 milligrams twice a day, you will get diarrhea. And if they come in, if they get that for a couple of days, they will say, I just do not like that googly guts. I have never taken this medicine ever again. And then the next thing they say is, I'm not going to start sticking myself.
Right.
So if you go up slowly, almost everybody can tolerate it. Yeah. Over time.
Now, does everybody know how to calculate insulin?
Yes.
Proper
by weight.
insulin dosing for everybody? Everyone knows how to do
Yes, in my
Is it
slide.
like 1.2
In my slide,
right?
Yes, it's in my slide. Hold on. Hold.
No, it was just there.
Oh, how dare you.
No, I just did it. If it's on your slide, it's on.
On my slide.
I just saw it.
There's 2 of them.
It's a pink one.
Someone was not paying attention. That's good.
Wait,
Fine.
no, there's only one.
I
Oh, yeah.
can read it from back there.
Point
So,
one.
so you either start with 10 units a day, or you do it depending if they're
Right, but if they're morbidly obese, what happens is you have
I
to.
can. Don't you go. You do
No,
it.
right.
You do it. No,
good.
no, you do it.
I just wanted
Ryan,
to-
do it. Ryan,
I mean, get in there.
But you could do point, depending on how big they are. So you could really start with 0.2, basically units per kilogram. But most of our patients are kind of in the 0.4 or 0.5 range. So you can do that. And then what you do is, let's say that they weigh whatever amount, You take
100 kilograms.
100 kilograms, okay? We do 4 units per kilogram. Then 0.4 units per kilogram. So we get that, whatever that number is. You take that, you divide by 2. There's your basal. And then there's your humalog.
Alright, divided by 3.
And then the humalog you basically divide by 3. And then that's what they're going to do. On average, that's what they're going to do at meal.
And that's your goal.
And as long as you've seen that the basal insulin overnight is dropping like 50 points, then you know that your basal insulin is enough. If you don't see that, then you got to up your basal insulin. And then once that is stabilized, then you sit there and you go through the humalog. The other thing that you can do is, because everybody's on the insulin sliding scale, you could do the insulin sliding scale, find how much total units that they have. And then basically when you have their total units, you can take that times by 0.75, so 75% of that of total. And then that's probably even more accurate than this, because this we're guesstimating when we see people with that in the hospital. And then you could take 75% of that, and that could be your true Lantus. Just want to make sure everybody.
Yay, Brian.
Yay, Brian.
Yes.
We have one more question.
Okay, I'm sorry, Steph. I didn't mean to interrupt.
Yeah, Brian.
We did this one. Okay.
A 15-year-old girl is in your office for a routine visit. Her mother has type 2 diabetes. No, a physical exam. She is noted to have a body BMI of 34 and acanthus negative cancer in her neck. Oh no. You check the A1C and it's 6.8%. She's only 13.
I know.
I should find medication appropriate to prescribe. That one.
Something with weight loss.
I feel like I'd start because she has diabetes.
Yeah, so it's the only medication that's approved for children older than
I
10.
didn't know that.
Yeah,
Yeah,
I picked it, but I didn't know that.
And then you would start them on, again, you would start them on, because, you would start her on because of the risk factors, right? The mental risk factors.
And she has
So,
diabetes.
yeah, so.
And the next questions you want to ask her, because she's 15, is are her periods regular?
Oh,
You
yeah.
know,
That's true.
these are also
Metabolic syndrome.
metabolic syndrome, PCOS.
Oh, I haven't
Oh,
had
yeah.
periods in like 4 months.
Sometimes you'll find a pregnant girl with this exact, body makeup that has never even had a period.
Yeah.
They just never started one. So the first thing you do is pregnancy test, and then the next thing you do is do a workup for PCOS.
That's me.
Good job,
These
Stephanie.
are more investigational.
Good job, Stephanie.
Very good.
I know this ring was like,
I'm sorry I hijacked your talk.
how dare you? You owe me lunch. I don't see that.
Good job, Stephanie.
Whatever. You were sleeping. Yeah, right. Yes, you were. Yeah, so I was right there. I got the. Okay.